Hey there, it's Dr. Justin Marcagiani. Welcome back to the podcast. We have a phenomenal guest, Dr. Jared Seigler, in the house. Dr. Jared is an amazing functional medicine doc and functional chiropractic neurologist specialist. He's a phenomenal clinician, really dives into a lot of difficult cases. And we're going to have a nice little conversation today on the functional medicine side. We're going to dive in on the functional neurology side and hopefully give everyone some good pearls they can walk home with. Dr. Jared, welcome to today's podcast.
Thanks for having me, Dr. Justin. It's definitely an honor, man. I love your energy. I love what you're doing. And I'm glad we can do this just to help spread the word, you know?
I appreciate it, brother. And you post a lot of great stuff on your Facebook page on a lot of clinical functional medicine stuff. It's really great. It's really good brain candy. I love it. And a lot of good clinical things, which as a doctor, I'm able to learn from some of the stuff that you post. And I think maybe some patients could as well. What are some of the big, more recent type of case studies or success stories that you're seeing in your office on the functional medicine side recently?
Oh, man. Let's see. And that's where there's such a big spectrum, you know, like my dopamine definitely surges when I get a letter or an email from an RA patient saying, you know, the podiatrist says I don't need to have this surgery anymore. Like my foot can evert, I don't need to have my ankle broken, stuff like that. So that's always really fun. But actually what really gets me is like when I maybe get more of the functional neurology type of things, when a mom is telling me like, Timmy got invited to the birthday, or just actually last week, there was a girl I was seeing, she's 10, and she would have this kind of thing where whenever she would get nervous, she would pretend to be a cat. And she would do this in school, and so of course all the kids are teasing her because she'll like hide and hiss at them and everything. And but then like from a neurology perspective, you know, I'm talking to the mom and she's like, yeah, she always bumps into stuff on her left side. And I'm like, that's what's called the parietal lobe. Like, where is my arm? You know, can I feel this? And I was like, the left arm is obviously the right side responsible for that. And I was like, that's self-perception too. Like maybe when we think of, example, people with anorexia, we'll usually find a lot of right parietal lobe because their self-perception is altered. And so we started doing therapy on this girl's left arm and left leg, like vibration and a trampoline and things like that. And now she doesn't pretend to be a cat in front of peers whenever she's nervous.
Interesting. So was that some kind of fight or flight mechanism that was just shutting down that left parietal lobe? What was happening there?
Well, there was some, she had some parasites. She also had some candida, and there was retained primitive reflexes too. So there was a couple things going on that should have gone away. You know, as the brain develops, we get rid of like, you know, that rooting reflex or that sucking reflex. And those were still there. So we had to kind of integrate some of those. But for her, a big part, the cerebellum, I say, you know, when we think of maybe the cerebellum, everyone's like, oh, balance. Balance is only 20% of what the cerebellum does.
Wow.
The other 80% is balancing mood. It actually balances the immune system. I've seen people have like a right cerebellar, like brain injury. Then they start developing autoimmunity, like, whoa, because the right cerebellum is usually like the brakes for like, hey, let's maybe not attack this, and, you know, things like that.
Yes, that totally makes sense. So I want to just be clear because you kind of, the reason why I like you so much is you really connect a lot of the functional medicine to the neurology, where you see a lot of like functional neurologists. They're just like, do this, spin this, look at this, but they don't sometimes connect the gut or the inflammation or the hormones or the diet. And it seems like you have a good blend. I'm just curious though, you mentioned parasites. Does parasitic issues always cause parietal issues, or can it cause another issue in other parts of the brain?
It can cause issues in other parts of the brain, but so kind of if we get a little scientific, parasites use a thing called Th9 or interleukin 9, and they start manipulating that branch of the immune system. The tool of that part of the immune system is histamine. And like I always tell when I'm training docs or even talking to patients, I say histamine and glutamate are like BFFs inside the brain. So now we're foggy and we're anxious. And the problem with too much glutamate, if the pedal's always to the metal, eventually that engine's going to start burning out.
Right.
So,
that totally makes sense.
Yeah, so we had to...
Stressing out the immune system in a way is what you're saying.
Yeah, so the way I kind of think of functional medicine, I say think of that like taking a protein shake, but functional neurology is actually exercising. So metabolically, we have to feed a muscle, but we also have to actually put in the work, you know? So I can't drink protein shakes and just magically like balloon up to 200 pounds with a six pack. I gotta go in the gym.
That totally makes sense. So let's just say for parasitic infections, could that potentially cause a cerebellar issue or a frontal cortex issue, or is it typically go just to the parietal part?
It can kind of be anywhere. It's what's called the triangulation theory. So say
Okay.
maybe someone's genetically susceptible to like one part of their brain, like, oh, mom's clumsy too. Well,
Yeah.
now we have like maybe with a parasite, like a global deficit. So maybe that right parietal lobe was already a little low, but now everything drops lower. And in relation, the right parietal lobe might drop even lower than everything else. So that's kind of where we might notice it first.
Very cool. So when we're doing a functional neurological workup, which I'd love you to just, and just so you know, people listening, this is also on video too. So make sure you click on the link below and go to the YouTube channel and watch this live assessment. I'm going to have Dr. Jared assess me. So I'd like you to just to kind of walk me or just, walk me through a typical assessment that you would have your patients do. And also just for listeners, Dr. Jared's one of the only functional neuro practitioners that does a lot of these assessments over internet and virtual, which is really awesome. So you don't have to travel a large distance, spend lots of money traveling. So he'd be a great person to reach out to. So when you're doing these assessments, what are the key areas you're looking at? Is it just the cortex, the cerebellum, and then the vestibular, or do you break it down further?
We break it down a lot further. We
Okay.
usually actually have people fill out 100
Wow.
questionnaire. It's only 100 questions, so not that bad. But then that gives me a sense of like, okay, are we looking at prefrontal cortex? You know, does the kid hit people? Do they have attention issues? Can they not make decisions? Are they poor with planning? Or maybe is it like cerebellar, like, oh, they walk funny, or they can't balance, or the vestibular system, for example, is typically if they're like PTSD, anxiety, like I can't go in a crowded public place. I get super nervous. Like, all right, let's maybe think of it as a vestibular lesion instead of like, oh, here's your Xanax or something like that. So you're kind of catching me on the fly where usually I have an idea like, all right, this is where it's going to be. But I usually start to think of the brainstem and the cerebellum first because those are usually the repair shop for the
Got
rest
it.
of the brain.
So right back in here and deeper, right? The big
Mm-hmm.
spot we're looking at. And so when we look at the brainstem, we're just looking at it globally. There's not a right or left of that, correct? It's not a
It can be like
yeah.
right now, like when I look at your face, I'm
Yeah.
looking for maybe do you have one eye higher than the other?
Mhm.
Do you like to turn out of the side? You know, is maybe someone's face like a functional deficit, like they only talk out of one side of their mouth? It's usually not like someone comes in with a stroke and they're just like this. Like that's
Yeah.
pretty obvious.
Yeah.
We're looking for like, hey, this person, they don't really smile out of the right side, you know, and it's only the lower half of the face. Let's start thinking maybe cranial nerve 5 or something like that versus,
Interesting.
you know, is it the whole face? So we're thinking of a motor strip. But anyways, usually one of the easiest things to assess is balance. So I say most people think they're good at balancing, but the true way to determine it, I call it the Flamingo Test. I'll like I'm standing on my left leg, and when I think I have my balance, then I close my eyes.
Powerful, man. I'm
A
doing
little
it right
bit
now.
harder. And then
Oh
we
yeah.
always want,
Because you lose the visual input for balance. So
yeah.
you're going totally off of the proprioceptors in the ankle, essentially, right?
Yeah, so now we're pure cerebellum versus vision is about 80% of balance. So the brain's
80%.
good at, yeah, the brain's good at giving a lot of illusions. You know, it can cover for itself. Like, oh, it's only
Yes.
a problem if we tease it out. So we always want to look for a comparison. Now we can try the right leg.
I'm doing okay. I'm a little shaky. There, a little. There, lost it.
Yeah, which it looks like the right's a little harder for you than the left.
It may be. It may be for
Yep,
sure.
so there's maybe a couple ways. So now we think, okay, maybe right cerebellum is the lesion or the area we're looking at. And
And
then
when you
we
say
have to,
lesion, just to be clear, like lesion just means it's that area that's maybe not up to snuff all the way, essentially.
yeah, it's not like you have a like meningioma or tumor
Right.
or anything like that.
Exactly.
Yeah, we definitely don't want to just like, oh, let's spin and look and ignore like
Yes.
a very bad process going on.
Right.
Now we're thinking, okay, what are the crossroads that feed into that? You know, is it more of the spinal cerebellum. So then we might want to try some core activation, like some dead bugs. Sometimes we can do some eye movements. So I'll just have people like follow their thumb. You know, I say like, pretend I'm a cop and now we think you might have been drinking. So we're looking for those smooth pursuits and things like that. So you have a tendency to try to keep it a little bit closer in on your left side. So, but that's okay. So that's all right. So now some things, so we can think of maybe eye movements, the vestibular system feeds into it, but so does the pons. So maybe something simple we can do is start gently rubbing the right side of your face. This is what's called cranial nerve 5. It's a lot of facial sensation.
Yeah.
Because when we think of the brainstem, those are cranial nerves. Eye movements, kind of the stuff to keep us alive. Like, hey, where can I put food in my mouth? Can I chew that food?
Right.
That's all cranial nerve 5. Yep.
Number 5. Got it.
Yep. So, because when you were a baby in your mama's belly, the pons and the cerebellum were actually the same tissue. One goes forward to become part of the brainstem, and one comes back to become the cerebellum. So we want to try to think, where's the crossroads? What's another way to activate that right cerebellum through what's called preneuronal pooling? What fires into that region? So now that we've maybe been doing that for a little bit, now we play what I call the game. Let's see if you can stand better on your right leg after doing that or not.
Definitely better.
Still not maybe a statue, but see, that's functional neurology, and that's
Yeah.
the beauty of it to me. Like, dude, you just surged my dopamine. That's why I love it, because the brain can change like that.
That's very cool.
Yeah, neuroplasticity happens real time, you know, maybe versus like, oh, we think of a CRP for a lupus patient. That can take a while for them to maybe quit eating this and kill this and that. And now we start to see them really going in a better direction, maybe over the course of a few weeks and things. But now we know, okay, that's your therapy. I used to be a strength coach or kind of a personal trainer that actually knows what they're doing. So
Yeah.
that's where I'd say, and then we'll start building a list of exercises. Like, okay, we found a way to fire into your right cerebellum. Now maybe if that parietal lobe is an issue or the vestibular sense is an issue, like I feel like I'm spinning or I get nervous or I don't like loud stuff in my ears. Like I see a lot of autistic kids and they're usually like, you know, they don't like that.
Yeah.
So then we might think, okay, is there maybe head movements we can do or specific eye movements? We just make it seem like games, you know? So now you have an exercise. Literally, I just tell people, guess what we're going to do? Like, it's that simple.
That's it. That's very cool. So let's just I want to make sure we take kind of people through the general, like, you know, areas that we can look at. So we have obviously the cortex in the front, right or left. And what would some of the big things that you would see come up on that questionnaire that you mentioned if there were deficits in those areas?
Yeah, usually like trouble with mood regulation, a lot of ADD type stuff. You know, the old guy that just says inappropriate things?
Yeah.
Prefrontal cortex is totally shut off. Like so that's where like, you know, I do have kind of a sympathy when maybe someone's on the stand in trial and they're like, I couldn't not steal that purse. I think they're absolutely right. Because that part of the brain, they know to themselves, like, I shouldn't do this. But the part of the brain that says, don't steal the purse, totally off. But so we start to think about maybe different parts of the prefrontal cortex. Orbital frontal, these are maybe people that are more violent. They might have urinary issues too. So they like hit their head and now they have bowel and bladder incontinence.
Yeah.
Or we have more of the dorsolateral. They can't plan. These are the patients or the family members. They're always late. They can't prioritize things. You're like, man, well, you can't adult, you know, type thing.
Interesting.
We have motor issues too, where maybe people are like, yeah, I start working out and my right side gets way tireder than my left. So then we start to think, well, maybe it's a cerebral cortex imbalance too. You know, and this left side is more math and this right side is more creativity. So back to maybe an autistic kid, they have a huge hemisphere imbalance. They're not dumb or anything like that. I don't know another way to phrase it. They're just not good at that social context. I can't read nonverbal cues. I can't get the joke. I can't make eye contact. But you give them math or some science, they're better than like 99% of the rest of the people out there. We look for a lot of eye movements too. So like, for example, the right cortex pushes the eyes to the left and the left
Yeah.
cortex pushes the eyes to the right. So we'll just have people boom, 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 boom. And then you can start to see one side will start to slow down. So, and then you can literally, and I'll ask people like, hey, which side was it starting to get harder to look at? See, like whenever you're trying to go from the left thumb over to the right thumb, you have a tendency to raise your left eyebrow. So we're starting to think you're doing what's called spreading your map. You're trying to compensate for a lack of one area. It calls in collateral neurons like, hey, I can't do this. So these buddies over here need to help me. So maybe I'll start moving my head or moving my jaw. You'll like see people like doing
I
all this
get it.
weird. I'm like, no, just your eyes.
I was feeling it a little bit harder to look over here, so that would correlate with that right cortex then, correct? Because the right's
Yeah.
pushing to the left.
Yep. So then whenever we maybe want to do a therapy on somebody, like, then we might like keep that in their right or in their left visual field. So that way we're over here more. So if it's like an Alzheimer's patient, for example, and they're like, yeah, I have trouble remembering the face, but I can remember the name. This is more of a face. We'll have them look at faces over here on that side. So we start kind of triangulating through different things like, look at this picture. Maybe we'll have purple in the background, which is more of a right brain type of color than maybe a red or a yellow. So once you know kind of how to play the game, it really does kind of become very simple, but very neat. So we'll start with the cortex, and there's different regions there. Then we have, you know,
And the
back to
cortex,
like,
we're talking right here. This is the upper part of the brain, and of course, the frontal is like kind of what makes us us, right? So that's the cortex. And then go ahead. What's the next one?
Yep, and then we'll usually start to look at the motor strips. You know, can someone move? Are they coordinated? Things like that. And then we'll look at sensory strips, which now we're getting into the parietal lobe. The parietal lobe, there's also like left-right discrimination. That's more the inferior part down through here.
Yeah.
So like one girl, she was at a business function, and this guy was trying to impress people like, oh, I used to be a tumbler or whatever in high school. I used to flip the girls in gymnastics and cheerleading. So of course she does that, and she hits boom right here on the back of her left parietal inferior lobe. She's like, I wake up and the whole bar is looking at me. That's how loud the thump was. And she's like, I can't tell my left from my right anymore. So then we're like, oh, there it is. So, you know, maybe versus, you know, can they do math in their head? Can they, so then we start to think parietal lobe. Then there's like the vestibular system. There's the temporal lobe. The temporal lobe is a lot of regulation of things too. Like, for example, whenever we look at violent offenders and maybe people that have been through a lot of PTSD and things, they usually have a right temporal lobe deficit. They can't regulate emotions anymore. We start to look at the vestibular system too. That one's really big because most people think of dizziness as the main complaint for the vestibular system, but that's actually anxiety. Anxiety is the #1 issue. Because the vestibular system suppresses what's called your limbic response, and that's a lot of the negative emotions correlated with survival. Am I afraid of something? Am I angry about something? So when I see people with all these limbic responses, I think, oh man, we really got to look at their brain. They're just set off like that. That's a whole nother conversation though. Yeah, so we start to think about that. The brainstem to me is huge too, because like when we think about maybe something like the basal ganglia, that's kind of like this, we have two like mohawks that run along each side of the brain, and there's a couple different pathways of the basal ganglia. One of it is do this motion, like shake someone's hand, but don't just push your hand out there so hard you end up punching them in the face. So then that's what's called the direct, is the do this. And then there's the don't do this, the indirect. So that shaves a little bit off what we say. So that way I'm talking to you, I'm not screaming at you. So usually we think of the basal ganglia with Parkinson's, you know, because this is like, I don't want my hand to shake type thing.
Right.
Yeah,
Right.
so the basal ganglia is fed by a part of the brainstem called the mesencephalon. So, and that's fed by a lot of eye movements. And this will be the people with the mask face. So back to like, we'll have them do,
No effect.
yeah. So we'll actually have them maybe do like reflexively move their eyes, because you ask them to look up, they can't look their eyes up, so
They
do
tilt up.
that to look up. Yeah.
Right.
So we'll have them reflexively like make their eyes bounce up through what's called OPKs or optokinetics.
Right.
Kind
But
of
that's
like
what the
if you,
strips, right? Like you have the
yeah,
little red, white, and strips, and you pull them up and you have them follow their eyes as you go through it, right?
yep, yep. So I just say think of it like you're driving by a picket fence. Your eyes
Yeah.
automatically try to find a new target, and you're just like bing, bing, bing,
Yes.
bing. Yeah. So reflexes are always stronger than thinking about doing it. So if somebody can't volitionally do something, we'll just go a step deeper, and we'll just hit it with a reflex.
So,
Oh
with
yeah.
a lot of these neurological issues, like what do you see as the root cause? I mean, let's just like take out like, all right, a car accident or like a physical trauma, right? I mean, is a lot of it more autoimmune? Is a lot of it more functional medicine, which autoimmune is still functional medicine, gut, nutrition, inflammation, gluten? Is it all of that? Because I'm just trying to look at, okay, if I do this eye thing, how is that root cause outside of the, it's stimulation to
Yeah.
that part of the brain, which may help it grow and get bigger. Like you said, muscles for, exercise for your muscles. The protein is the metabolic. What's the
Mhm.
root cause? And can you break that down?
Yeah, all things being equal. So one of my favorite mentors is Dr. Karazian, and he's what's part of what's called the MEND project, where there's only like four, I believe four kind of ways that they can actually measure the brain's function real time in the entire planet. And I asked him the same question: what's usually degrading people's brains? Without hesitation, he said stress and negative relationships. He didn't talk about food. I mean, don't get me wrong, that stuff's bad. Dysglycemia, like
Yeah.
if we're going to develop Alzheimer's, we're doing it right now. It
Right.
just takes 60 years for the brain to break down enough to where now I don't know who I'm talking to, and I'm like, oh, I forgot to put pants on type thing.
Yeah, exactly.
Stress will always do it, and stress can come in many forms. Toxins like glyphosate,
Yeah.
metals, which run rampant, blood sugar imbalances, people getting shaky between meals, people getting tired between meals. Huge, huge problem. And I'm glad you brought up autoimmunity. What Dr. Vojdani found,
Yeah.
big nerd
First of China.
immunologist,
Yeah.
98% of people have auto or self antibodies to brain tissue. It only really becomes a problem when that blood-brain barrier is broken. So
Mm.
we're all basically walking around with neuroautoimmunity. We just don't know it. Like I see a ton of POTS people, like a
Right.
ton. It's everywhere now.
Yeah.
And there's a reason for that. That's an autoimmune disease. So now the brain can't regulate the heart rate, and someone stands up or they go shopping and they just boom,
Yeah.
pass out, hit their head. So from a root cause analysis, we see a lot of things stemming from the gut. Obviously, infections like Parkinson's. We know now that those toxins will walk their way up the vagal nerve into the brain stem.
Yeah.
Smelling a lot of bad stuff too. Blood sugar issues, chemicals in foods. Wi-Fi is actually extremely problematic. Like we see a lot of molds degrading the brain, like at an alarming rate, actually. What they did with all neurological antibodies to the brain, here was like, okay, here's the autoimmunity before. Let's expose them to mold, skyrocketed. The amount of how the immune system started to attack the brain was just crazy high after that. Um,
Wow. Very interesting.
so yeah, so that's where when, of course, we do want to take that functional medicine approach, because back to like, you stroking the side of your face to
Right.
stand better. If you're like drinking alcohol every night to cope with a poor relationship, who gives a crap about stroking the side of your face so you can stand better? You
Exactly.
have seriously big issues going
Yeah.
on.
Yeah.
Yeah,
And
so I'm from Oklahoma. We would call it farting in a tornado. You ain't gonna do a lot.
yeah,
So
that totally makes sense. Yeah, exactly. In Boston, where I'm from, they call it pissing in the wind. So I totally, I
yeah,
totally know
that too.
what you're saying, man. Also, you said mentioned a couple things about dysglycemia and blood sugar imbalances, which I think are really important. But there's also a lot of stuff out there, which I posted a lot of content on it too, on intermittent fasting being so beneficial. So if you had dysglycemia and you started incorporating more intermittent fasting, could that exacerbate this person's symptoms more?
It can. I'm after a big thing called metabolic flexibility. I know
Mhm.
everyone, and ketosis can totally be good. We utilize that dietary tool
Yeah.
all the time. But if somebody can't miss a meal and we're like, hey, you're going to go 16 hours without eating, their cortisol is going to shoot up sky high. They're going to start degrading the brain even faster. So
Right.
usually we'll have to get them to the point they can miss a meal.
Right. It's kind of
Yeah.
like someone that can barely walk and you're like, yeah, I want you to go run a marathon right now. That's the equivalent of like an intermittent fasting episode, essentially.
Basically, yeah. So we'll get them to the point like, hey, I was able to, postpone lunch a little that day, doc, and I didn't like snap at Becky in the office. I think good. Now we can
That's better.
start to utilize different tools. Yeah. So obviously, you work with a lot of patients too. We have to do the right thing at the right time, because what we don't want to do is push someone so fast we push them over.
Right. So you want your body to be more metabolically flexible, but it may take a few months, nutrients, some things, some, reduction of stress, cortisol, those kind of things to get you to that point where you could start to move in that direction, essentially.
Yeah, absolutely.
And it's interesting because you see a lot of people that aren't practitioners and they kind of have this panacea approach where this thing has to be it. And if you can't do it, you're doing it wrong. And I think as a clinician, we can look at it and just say, well, no, it's just, you're here, you're telling me we got to get to here. And if I can't make that jump all at once, then, there's probably some baby steps we have to make in between to get you to that spot. Does that make sense?
Yeah, absolutely. And that's where the internet can be a double-edged sword, because what worked for you probably won't work for me.
Right.
Even though we're both white boys, even though we look different on the outside,
Yeah.
we're more than 100 times different on the inside. I can guarantee it.
Right.
So that's where, when something works for one person, they usually extrapolate that and think, okay, well, this worked for me, now it'll work for everybody.
Right.
And, we've obviously seen that's not the case, because two people maybe try to do the same thing, even though they maybe have the same label, like, oh, Alzheimer's. And one person gets better, but the other person, they just start degrading faster and faster and faster.
Yes. I had a patient just before I got on the phone with you here where we started this person on kind of like a ketogenic paleo template for the first couple of months of care. Did really well, really good improvements in acid reflux. I mean, he had some parasites and some other issues. We cleaned that up. But then there was a point he kind of hit the wall and his sleep wasn't getting that much better. It was about 50% better. And then we just started adding a little bit more carbs in at nighttime. And magically his sleep started to improve and he could sleep throughout the night. So there's some like metabolic shifting that happens where what works maybe in the beginning of care may have to be tweaked as you continue to progress through care.
Yeah, I always do try to think about, like, when we think of a ketogenic paleo type thing, I don't know about you, but if I happen to stumble across like a peach tree, I'm going to eat a ton of peaches.
Yeah, exactly.
That's where I think carb cycling usually works better than maybe straight ketosis. The only way I've seen ketosis working long term is if people are just dumping ketones down the hatch. They have to supplement. They're never going to make it, especially women. That's where I think of that metabolic flexibility. Our body was designed to use protein as energy, use carbs as energy, use fat as energy, use nothing for energy if we just suck at hunting and gathering and we didn't get anything that day.
Right. Exactly. That makes a lot of sense. To give me some great knowledge bombs here, just to give people a general overview of what you do on the functional neuro side. Is there anything else you can do just from a quick at-home assessment on me that maybe someone could look at in themselves and then maybe apply an exercise or two? Is there anything else we can do here as a worker through?
Yeah. One of the things, so with the premise of functional neurology, it's basically do what you suck at. That's kind of one of the general rule of thumbs. And maybe if like back to balancing, it might be hard to try to sit there and keep balancing and balancing and balancing, but you got to try, because if you don't use it, you lose it. So that's where like
I should be trying to do like stands like this during the day with my eyes closed on each side, essentially.
Yeah, kind of. And since we're thinking about the cerebellum, we're thinking about the foot. Like if you were to get on like a rebounder or something, then I'd say like get a vibration sense. Like maybe have your wife just start tapping it by your foot. And that's sending a ton of proprioceptive input to that region. See how you kind of lost it?
Yeah.
So that's where I would say it's kind of like riding a bike. You got to keep practicing and practicing and practicing until you can do it and go 30 years without riding a bike and still remember. That fancy word is called long-term potentiation.
Yeah.
Meaning that those connections have stuck around and now we don't have to maybe keep rubbing the side of our face. So something that you could do, for example, would be after you start rubbing the side of your face, that's when I would say now you want to do your balance exercises, because we've activated that part of the brain. So now we want to remap it through that proprioceptive input. We can do that through vibrations, like 128 hertz tuning fork. I know you still got it from school.
Oh, yeah, it's hiding over
That's
here.
like the best $8 for functional neurology ever. Oh my gosh. I even tell people, like, just go buy this. It's on Amazon for like $8. Like my chronic migraine, TMJ people will start bing and putting that on different places on their body and maybe put them through an active range of motion. They love it. They can't get enough.
Very good. Yeah, I'm excited. I want to do your functional neurology course, even though this one's meant more for patients. I know you said you will be coming out with the doctor's one at some point. I'm giving you a little push there to do that because I'm excited for that. But yeah, sign me up for your patient course, and I'm going to definitely get this out to my listeners because this is, I think, really invaluable information. Is there anything else we can apply right now to me that we can also, that listeners can look at? So you said, like, okay, this stuff, like the one leg stuff, I get that, like the stroking of the face, and you were able to assess that off of which leg, what I couldn't balance that off of. And then also we did the eye thing, and it was like, which one do you feel like is the harder one to go to, or the
So
slower
say,
one?
for example, if you have trouble looking off to the left, maybe you can start at midline and just go a little bit, you know, like you're not going to bench press 300 pounds the first time you go in. You got to work up to it. So say maybe we'll go here, and then as you get better, we can go here. Then as you get better, we can go here, and then we can keep going until you reach what's called fatigability. You start to notice, like, man, I'm raising my eyebrow. I'm trying to move my head instead of move my eyes. It's like a set of bench press. Stop, rest, wait for the next set. You got to save it, because if you start doing it wrong, you're just going to call in those collateral neurons that you were already trying to use.
Your jaw, your eyebrow, right? Some of these muscles here, right?
Yeah.
These facial muscles.
Yeah, and then kind of a big thing for the people that have inhibition control, we call them antisaccades. So that's where if someone holds their thumbs up, we'll say, look at the thumb that doesn't move. So I'll have people like look at my nose, and then I'll say, look at the thumb that doesn't move. And then they'll see, you looked at the one that moved.
Yeah.
So you have to say, don't look at that. That don't pathway is don't steal the purse, don't hit Timmy, don't do this. So I'll see this in a ton of ADD kids. And like I can see them, they're practically sweating trying to not look at the thumb that moved.
Right.
So yeah, so that's where we'll provide a stimulus, like red light, green light is a good game, and we'll have them focus on the red light, like teach that brain how to make them stop. And then to focus back on the ADHD, because I know we only have a little bit more time, we want to have them count to 5. Say they look at the thumb that doesn't move, 1, 2, 3, 4, 5. Because you tell your brainstem, actually look at that, really focus. Don't just look at it, bounce around. Because if you notice when you talk to people, their eyes are usually all over the place. They can't even focus on one stimulus for that long at all. How can we expect them to focus on math for longer than that?
I understand. So if I don't have your assessment yet, right? And I'm like, hey, I want to be better more neurologically. Like, what are those top three things? Is it literally the ankle stuff? Is it going back and forth with the eyes? Is what are those couple of things they can do? And how long does a rep look? 10 seconds, 30 seconds? And then how much do they rest?
Yeah, it can depend for that fatigability. Like if people can only maybe do like 5 or 6 saccades or look to a target, then I say 5 or 6 it is. And I usually have people do that like 4 or 5 times a day. Like, hey, you're going to the bathroom. That way you don't look weird in front of your coworkers. Like just boom, 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 So eye movements are good, but all things being equal, true exercise, having a goal for that exercise. Like my Parkinson's patients, I straight up tell them you're going to preserve your brain better by every day than just doing some eye movements, looking at some OPK tape, and maybe working on your balance. Gratitude is probably the biggest thing. We give people journals, so actually having something you're grateful for. Because if we want to maybe direct blood flow to the prefrontal cortex, we have to get out of that stress response.
So the gratitude is like forward looking, like I'm thankful for all these things right now here versus being brainstem, fight or flight, you're back here essentially.
Yeah, blood flow is huge.
Shifting that blood flow by what part of the brains you're activating essentially.
Yeah, and caveat, if you or someone is actively having strokes, please don't try to start doing functional neurology. We will change blood flow to different regions of the brain, and the last thing we want to do is blow another pipe out. Yeah, absolutely.
Okay. That makes sense.
And I would say gargling. We're so sympathetic driven, we have to get back in that rest and digest. So when we think about blood flow, when someone's stressed out, basically everything below their diaphragm shuts off. We're not going to digest food. The liver's not going to detoxify. Ovaries and testes aren't going to make sex hormones because those things aren't important for survival right now.
So gargling, couldn't we also do more nasal breathing, you know, focus on more
Yeah.
nasal? Like
Yeah,
maybe
breathing through the diaphragm.
That's
And
excellent.
when we think about a breath count, kind of the command center for the vagus nerve is called the nucleus tractus solitarius. I know big
Yeah.
words. But that's where we'll do a 4-8-4 breath count. In for 4 through the nose, out for 8 through the nose, count for 4 before you breathe in again. Because our autonomics, if I say control your pupil dilation and your blood pressure, you can't do that. But you can control your breath. So that's kind of our window into our autonomics.
So it's 4 in, then pause for 4, then 8 out? Or is it 4 in, then 8 out, then pause 4?
Yep, 4 in, 8 out, pause 4.
Wonderful. That's great.
Yeah.
Awesome. And
Yeah,
we're going to put the links for the course for the listeners here below. And do you know when that course goes live, Dr. Jared?
We're trying to shoot for mid-March. I got to shoot a couple more videos and then get it nice and pretty. I'm not the one that's like, hey, let's make it a PDF and let's make it, I'm left brain nerd dominant, man. Creativity is not my suit. So that's where we have the right people to do that. But yeah, we're looking to definitely get it out sooner rather than later, for sure.
Well, please email me and let me know. I want to be part of that course as well. I think this information is phenomenal. And then we'll make sure if this video comes out too soon before the course, I will make sure the links are updated as things come live. So make sure you get those out to me and we'll make sure all the listeners get it. I think this is amazing information. Your website is becomeproof.com, part of the Living Proof Institute. That's the easy URL. Are there any other ways the listeners can get in touch with you?
Yeah, I'm on Facebook. Just look up my name, Jared Seigler. I think there's 2 of us. I'm the one that looks like me, so that makes it simple.
That's an easy one. I love it. Anything else, Dr. Jared?
Just be gratitude. You know, it's easier to be nice to somebody than mean. So that's just what I found in this life. If we're grateful for what we have, then that's a big step. Because if we don't appreciate what we have, we'll never be grateful for what we get.
It's so much easier to say, hey, be grateful versus, hey, activate that blood flow to that frontal cortex. It just sounds so much nicer saying it that way.
It is. I try to keep things like my dad told me, keep it simple,
real.
stupid.
That's it. That's it, man. Awesome, Jared. Well, I appreciate your time and the massive knowledge bombs you dropped here today. Thank you so much, and you have an awesome day. We'll talk soon.
Thanks for having me. Everyone have a great day.
Thank you.